Thank you so much, Mia. And this has been an amazing meeting, and every presentation has been exceptional. So thank you to all the speakers and moderators. I am really excited about this next discussion today with three incredibly passionate and skilled researchers, clinicians, and practitioners. Dr. Mark Swain, hepatologist and professor of medicine from the University of Calgary, Dr. Ken Cusi, endocrinologist, professor of medicine from the University of Florida, and Dr. Ming Jung, primary care physician with a focus on MASLD and MASH from the Liver Clinic at the Albany Medical Clinic in Toronto, Canada. And we'll be discussing the importance of interdisciplinary collaboration between primary care, hepatology, and endocrinology. So in the new world of MASLD and MASH, why is it so important to have interdisciplinary collaboration? Anybody who wants to start? Mark.
Well, sure. I think broadly medicine's shifting towards interdisciplinary care anyways. And so I think when you have a disease, which is really a metabolic dysfunction associated disorder, there are going to be different individuals who are going to play major roles. And I just believe that care has to shift in a way where people who have an expertise in a certain area, whether it's primary care or endocrinology or cardiovascular or hepatology or obesity management or whatever it might be, it's critically important that they work together and talk together, and so that the patient, I think, was in the earlier presentations at the center of the circle, and everyone's focusing on the best outcomes for an individual patient.
Thank you, Mark. Ming, from the primary care side? Nope, you're on mute.
Am I on mute now?
Yes.
You're good.
All right, thank you. Well, I need a multiple disciplinary team to teach me how to unmute my my presentation. Well, as a primary care physician, we encounter really difficult, sometimes complex cases. A MAFLD patient actually has multiple other comorbidities, and I think to handle all of them by one physician, I think it's really not realistic. And it's very important to actually call for help when we need it. Primary care family physicians are trained in many areas in managing diabetes as well, but only to a certain extent. Medical knowledge of fast approaching, fast improving. We need to also know in managing diabetic patient with MASLD or MASH, is the medication that we choose best for both. So those are important questions that I think we really require multidisciplinary team in diabetologists and also in hepatologists in assess and how to manage patient with advanced fibrosis.
Thank you. Dr. Cusi?
Hi, you can call me Ken. Hi, Mark. Hi.
How's it going?
You again.
Just being polite.
Yeah, people are so stiff here. Hey, it's so late in the evening, and I'm sure the audience are munching as they listen to us. But Michael, answering your question, I mean, what has just been said is really critical. I mean, it's a time for a paradigm shift. If patients are really needing a set of skills from a group of doctors, and it cannot just be followed like every 3 months. I mean, by working as a team, we have a way of impacting from different angles, seeing them more often, and more than anything is diseases are not anymore in a silo. You know, it's not like when I trained, liver for me was just liver metabolism. Then it expanded to lipid metabolism and maybe cardiovascular disease and so forth. And now, taking care of diabetes is a task of a team. This is the analogy with, for example, in many areas of diabetes, where, for example, diabetic nephropathy. I mean, this is not something that we ever consider any longer just for nephrologists, just for the endocrinologist. And actually, it was primary care who really led to the decrease in diabetic nephropathy, as they see 90% of the patients and they're very, very skilled in giving them the right treatment with the many drugs we have now. So I think the model of diabetic nephropathy of diabetes is going to apply to the liver. I think endocrinologists are going to be gastroendocrinologists, and I hope hepatologists are going to be a little bit endocrinologists too, and primary care doctors. When we talk, I don't like to talk primary care physicians, a primary care team. They work with nurse practitioners, with nutritionists. It's going to be successful. I mean, I still see hepatologists who say, go lose some weight and come back in a year when they have moderate to advanced fibrosis. I think that model is just old. I mean, as we heard from Steve, I mean, we have a hepatologist that's treating with GLP-1, but look at nephrologists. They're also using SGLT2 inhibitor. They're using diabetes drugs. So drugs don't belong now to a field anymore. So this is the obvious evolution of care.
And just to add to that, I think if you look at the popularity of GLP-1 agonists across the board, it's people are becoming patients are becoming very educated about GLP-1 agonists, and they're coming to their primary care physicians, actually seeking them out for weight loss, and so this is a big driver of use of those medications. And I if someone came and they were depressed in our practices, we would be considering an antidepressant and the interventions you would need. But here people have been coming forever, and we've been telling them to lose weight and come back and see me in a year, as Ken said. And now we have tools that can help us actually facilitate weight loss, and I think we need to be embracing them more. And as Steve mentioned, it's really weight loss is the key focus to try to help people with current medication that we have available, to try to help them deal with their metabolic dysfunction broadly, because it has heart, kidney, diabetes, weight loss. All of these parts are impacted by those medications. And I think we all need to get more. Obviously, Ken's very familiar with using them, and probably Ming too, but I think people need to be more broadly aware of medications that are attacking metabolic dysfunction.
My last little comment, Michael, we won't let you talk tonight, I think. But to round up the concept that Mark said, why primary care? To be honest, they're at the forefront of diagnosing, and they'll be at the forefront of treating, because the SELECT study has added a new twist. The SELECT study with semaglutide inducing a 20% reduction, almost like a statin level reduction in cardiovascular disease. I mean, whose drug is a GLP-1? It's not an endocrinologist drug. It's everybody's drug at this point. And again, except for the terrible abuses on price in the United States, I mean, it is really going to be the metformin, for diabetes. And on top of that, then we're going to be adding a lot of things. And again, it's not the wonder drug cure all, but it is a good baseline to start with.
I think with primary care as well, given the fact that this new medication might not be accessible financially to our patients, to have the team is also to add the dietitian, to add the lifestyle coach, that together we can manage patients much better. At the Albany Clinic, we also have the ability to have actually a dietitian for diabetic patients, and we actually utilize them for fatty liver disease that has prediabetes to diabetes for management of both. So it's nice just to have the primary care team there, right there. We can provide a better and broader help as well.
Mm-hmm.
Thank you. I wanted to ask a question that had to do with two of the previous speakers too. So Jeff Lazarus talked about the community of practice limitation, that we're really not ready for the future. And at the same time, Marinella talked about the fact that very often patients have a year from the time they're diagnosed until they progress to very serious liver disease. So how are we going to get there? We have you three representing three specialties, and there's others also, but how are we going to get there soon?
Well, exactly by what we're doing now, educate primary care providers, educate the risk factors for MASLD patients, so that we know people that comes in with obesity, with metabolic syndromes, with diabetes, we need to do ALT, AST platelet counts, do a simple FIB4 and abdominal ultrasound. I think that we enable us diagnose them early, treat them early, and prevent progression of disease as well.
And I think a fundamental issue that we all need to really balance or I think discuss more openly is that when we're talking about GLP-1 agonists and we're talking about eating healthy and things like that, there a huge proportion of certainly the people that I see in my clinic with fatty liver, there's no hope that they're going to be eating a Mediterranean diet or, farm to table. I mean, they're just happy to have time to eat. They often have multiple jobs and they really have trouble affording food essentially, and they pass that on into their families as well, because they're all, of course, eating the same meals. And then to afford a GLP-1 agonist for weight loss, of course, because they're not covered in Canada, even if they had a health plan to pay for it, it puts them out of reach. So unfortunately, there's this huge segment of people that have the risk factors and have advanced fibrosis that we really can't even address because they can't access those medications or a diet that's going to be healthy. And exercise, of course, if you're working 2 or 3 jobs, you're not exercising typically.
Yeah, but Mark, I think still we don't have to give up on them, right? And I know you don't.
No, I don't.
But I think just at least, for example, simple things, removing the junk food or bringing their own lunch with maybe a healthier choices.
And no pop.
Then, if they have diabetes, using, improving the diabetes control. I like pioglitazone. By the way, 15 milligram, which is the lowest dose, does not cause weight gain. So it's a neutral dose, and it's a $5 a month medication. So again, it's a very tough situation to be, as you say, when you have food insecurity or several jobs. But I know you have a lot of skills in trying to at least get them closer to target.
And I agree with you completely. I think that we need to become more policy savvy and advocates, I think, as well. And that's part of multidisciplinary approaches. Often if you come as silos to policymakers, they don't necessarily listen the same way as if you come as a group. And especially if you have a patient voice, I think you have much stronger case to change policy.
Absolutely. And I think in that regard, I like to involve public health, because I do think MASLD is a public health issue as well. And I wonder if public health can actually involved in educating general public and educating physicians and forming some kind of policy as well for a better and healthier lifestyle.
Ming, how often are patients coming back to you after going to the specialist? And I guess the same thing for Ken and Mark. You're seeing more patients being referred than you need to, I think, because we talked about different algorithms now that are going to reduce that. But are primary care physicians still seeing a lot of the people that should be referred or held instead of referred, or how is the mix right now?
Well, I cannot answer you on that one, because I think FIT4, the knowledge of screening patient referral is just starting right now. In my own clinic, in my own experience, that we do have regular follow-up with people that's with fatty liver that's at low risk, and primary care physicians are quite good at following them, especially those people with diabetes, because we are seeing diabetic patients every 3 to 4 months, and the continuity care is there in a very good, well-organized primary care settings. So I would say in our setting, our physicians are well aware and well educated, and they do follow patients very well with their diabetic control, and they do refer back to FIT4 or for FibroScan as well. But I think with this meeting, this conference really is to educate general primary care physicians to be mindful of the people that's not referred, to follow them on a yearly basis, especially those with high risk. And it should be quite easy to do, because we do follow their other comorbidities like obesity, hypertension, hyperlipidemia.
there is a lot of overlapping on a lot of these syndromes that are going on. And Ken and Mark, so are you feeling overrun with the referrals you're getting, or there have to be some changes from primary care now?
Go ahead, Ken.
Well, I mean, they don't send them to me as an endocrinologist for referral. They'll send it to the liver doctor, right? But I can say that still, I mean, although there's a bigger effort in using, we talked about FIB4, I think that there's still a lot of space for improvement and doing it more routinely. We have it embedded in our electronic medical record. We started a care pathway where we schedule the second test and the doctor gets a feedback when it's there. But again, the typical question is when to send for that referral. And the referral would be when that second test is positive, which whether ideally, I'd like more an imaging test like the elastography. ELF is available in some places, but it's much more expensive. So I think, to be honest, this is going to settle as we learn more and become more of a routine, pretty much like we did with nephropathy and so forth. Mark, on your end, you're the one who gets the patient, so.
Yeah, so I mean, we're broadly, I would say we're fortunate in Calgary because we have a screening mechanism in place. I think the issue but certainly we're seeing a huge number of referrals, and it will be unsustainable really to be able to see them. And so I think what'll happen, similar to what happened with FIT as a way of getting a colonoscopy in certainly in Alberta, is that you start the cutoff is changed to make sure, because you can change cutoffs on tests to that will influence the referral patterns. Essentially, we know that about a third of people are going to have a FIB4 above 1.3. So if everyone gets referred, that's 1/3 of 25% of the population. That's a lot of people. And so if you don't have a secondary test readily available, which is they're hard, like alpha is not available here, and to get a imaging test it can be quite challenging in most places. So it becomes problematic, and so you're referring a third. And so that I could see the cutoff going higher over time in places that don't have access to a secondary test, to try to at least get the people at highest risk through to see a liver specialist.
In that sense, I would say, Mark, and I know, Michael, you had a question, but real quick. So 1.6 would definitely catch people who are positive. The problem maybe is for people with diabetes. There's a lot of people with F2, F3 in the 1.0 to 1.3. So that's a little bit with the challenges, but they don't need to have a fiber scan immediately. I mean, they can have it anytime. They can be done in the next 6 months, as long as it's done and it's part of the idea of doing it. I know there's no perfect answer. With FIB4, we tried to make it as simple as it could, but the FIB4 has caveats that probably were discussed earlier.
And I think I think as Ming said, we're just at the start, and so there will be better tests that'll come along, and and I think that'll enable us to be better at screening people and having the right people see the right people at the right time. And so we just need to get people comfortable that with the concept of screening in primary care, and then as the tests get better, I think we'll get better at it. We'll be able to see the people according to need.
Thanks, Mark. I'm going to start with Ming. Just we have about 2 minutes left, and I wanted to give each of you an opportunity. We don't get this very often to have a primary care focused audience like this. And so what's the one message that you want to get across to the people that are here tonight? Ming?
Please do FIB4 in patients that's with increased risk of MASLD. People that with diabetes, especially pre-diabetic patients, people that has 2 or more factors, metabolic syndrome, and obesity patients, and people that's from a high ethnic background with genetic variations for NAFLD.
Thank you. Ken?
Yeah, just think about liver disease and diabetes. I mean, I've never thought that when you have diabetes, I have to convey a message that you're at high risk of liver disease. To the same extent, I would say it for kidney disease, it comes more naturally. So we need to incorporate the liver not only the diagnosis, but in the cardiometabolic management. And interesting, the drugs that may help these endpoints may help the liver as well. GLP-1s, PIO, SGLT2 inhibitors, and combining them might have this multi-organ effect that also will improve cardiovascular disease. So think liver and think of the patient in a comprehensive, holistic, long-term way.
So the liver is the center of the universe?
Of course.
No. Remember, I'm an endocrinologist. That's the pancreas, you know. the beta cells.
You're on a roll. I had to go with that.
I think that the way I always, when I'm chatting with primary care physicians, is to say the problem is that you have a patient in front of you, and traditionally it's very hard to know if that person's at risk for liver. You know that you're trying to do weight loss and you're working on their diabetes or whatever, but do they have liver disease or not, and should you be worried? And so it actually, doing a FIB-4 is empowering, because if FIB-4 is less than 1.3, you're empowered to not worry about the liver disease at that point. You should do it sequentially every 1 to 2 years or whatever, and maybe a diabetic every year. But it allows you to focus on the other aspects, and you don't have to worry. You can look at the patient and say, look, I'm not worried about your liver. I'm worried about these other things. But if it's above 1.3, you can say, you know, maybe I need to worry about your liver a bit, so I'm just going to go send you for another test, but we're still going to work on these other things. And so it actually allows for a richer dialogue with your patient and a more of a holistic approach.
Great. Thank you, Mark. So Ming, Ken, Mark, thank you for a really great conversation. I wish we'd go on longer, but we still have more work to do tonight. So thanks so much.
Thank you. It was fun.
Yeah, pleasure.
See you later. Yeah.
Bye, Mark.
Bye. Bye, Ken. Yeah. Bye, Ming.
Bye.